So thank you also to those who are remaining with us online. It's really great to have you online, and I know you're watching from all sorts of different places, so welcome and feel part of the whole conversation, I hope, as well. And of course, we want the conversation to continue after the course of these 3 days. And thank you so much also for being in the room. So the first discussion we're going to have is advancing global health equity centered on women and children. It is a very important topic. And just to set the scene, please welcome to the stage Nicola Beer, who is Vice President of the EIB.
Thank you very much, Lisa. And I'm very, very happy that you are all here, because I think that this is not only a very timely discussion, it is really a discussion which matters. Despite extraordinary medical progress, access to timely and affordable care remains the defining health challenge of our time, and especially for women and children. Every 2 minutes, one woman dies from preventable causes. A child in the poorest regions is 10 times more likely to die before 5. Increasing backlash against gender equality in some parts of the world is also reversing hard-won gains in women's health. Closing the women's health gap could boost the global economy by at least $1 trillion annually by 2040. So supporting women's health is the right thing to do, and it is a smart thing to do. And in the current context, an urgent and necessary response to trends that threaten the well-being of entire societies. And this is exactly why the EIB group is engaged through partnerships and scale. Most of the tools already exist. We need to ensure they reach the women they were developed for. We need innovative financing that brings public and private actors together, pools expertise, and creates shared value. Europe is an ideas powerhouse and a sanctuary for researchers. As one of the largest financiers of health, the EIB group supports innovation and those driving it through initiatives like TechEU and our Summit for Women Leaders in Life Sciences. With many of our partners here today, we are expanding access to medical specialists, state-of-the-art diagnosis and treatment, contraception, maternal medicine, vaccines, and digital health platforms. So innovation reaches women everywhere, especially where the gap is the widest. We work with UN partners, the European Commission, Gavi, the Vaccine Alliance, UNFPA, FIGO, and other multilateral development banks and philanthropies like the Gates Foundation to support access to safe and affordable contraception, vaccines, and primary health care, Angola's first HPV vaccination campaign to protect 2 million girls, primary health care services, including reproductive health and gender-based violence prevention in Lebanon. Together, we also back locally led health security and resilience solutions through the Human Development Accelerator and mobilize over 1.5 billion for health system resilience in low and middle income countries through a health impact investment platform. But health equity is inseparable from economic empowerment. Through our flagship gender initiative, we strengthen climate resilience, food security, and economic opportunities worldwide in line with the Global Gateway. It also depends on broader systems, from infrastructure to climate resilience, in which we also play a vital role. We have embedded gender equality into our business model and launched a new action plan to further support gender equality politically, economically, and financially. So today's discussion is really about advancing health equity. We know the problems and we know what works. Together we need to scale solutions and keep women's and children's health at the center of decision-making. The challenges are systemic, but they are solvable when political will, financing, and partnership move in the same direction. This panel brings together exactly the voices we need to solve it. So let us focus on action, because the cost of inaction is far too high and the opportunity is too great to miss. Thank you.
Thank you so much, Nicola, for setting the scene. And without further ado, please welcome your moderator for the next session, who is Valentina Sartori, a partner at McKinsey. And her panelists joining her on stage are Kitty van der Heijden, Deputy Executive Director at UNICEF, Aparjita Rameshkrishnan, Director for Family Planning at the Gates Foundation, Morena Makwana, CEO of BioVac, Kira Pauli, Managing Director of Bayer Foundation, and Alexandru Rogobete, Minister of Health from Romania.
Thank you everyone for being here. I'm excited to be moderating this panel with this exceptional group of health equity champions. You will see that we have a great representation across different types of stakeholders, from a ministry, from UNICEF, from, let's say, pharma, but philanthropy at the same time, vaccine, and of course, a great foundation like Gates. When we prepared earlier, we said, look, let's make this as interactive as possible, so don't shy away from asking questions. Very difficult ones, go to the minister, right? But he said he wants them. But jokes aside, let us get started. Thank you, everyone, for being here. Maybe I start with Kitty. Kitty, you and UNICEF are spearheading, protecting the most fragile, women, children, adolescents. I would love to hear from you how the system is still failing them, in particular in certain settings, but at the same time, what are the ideas, innovations, and partnerships that you see as most promising to close the gap in health for those groups?
It works. Look, first of all, huge kudos and thanks to EIB for putting health equity on the agenda. I don't take this as a given in a financial setting. I am too often in meetings where it doesn't happen, so this really requires a shout out. And when it's about equity, it's very often about women, and they're hugely important. There can be no doubt about that, as I represent one, but children are often falling off the mind map. And unfortunately, today, it is still where you are born or where you give birth that determines whether you will survive and thrive or not, right? And we know that 80% of maternal and child mortality is happening in South Asia and Sub-Saharan Africa. And it's even worse in conflict areas, and unfortunately we see an increase in that. 50% of children that die far too early, that happens in conflict and fragile settings, and over 60% of maternal mortality happens in conflict settings because we simply can't reach them. And, you know, we're turning 80 this year as UNICEF in a few months, and we were born on the ashes of the disaster that happened here in the Second World War to help children. And what we see now is an increase in conflicts. 1 in 6, almost 1 in 5 children either living in conflict or fleeing from conflict. And in those settings, it's extremely hard to reach them. So that to begin with. But where I think we are failing women and children is at those moments that they are transitioning to a new phase in their lives. Adolescence, early onset of pregnancy, childbirth, postnatal care, because that is often when the health system simply doesn't provide for them. And of course, that is much worse in conflict settings because you're also facing a totally dysfunctional healthcare system. There are no supplies that reach, and there's no capacity in the healthcare system, the frontline health workers, to take care. And then if you are unlucky enough during those phases to be an adolescent girl, you're even more disadvantaged, right? Because of harmful practices, because of gender norms, because of a health system that simply isn't made to respond to your needs as an adolescent girl. Now, for me, what is important and what we've learned in UNICEF is that it's a difficult start in those settings for women and children, but it doesn't have to end badly. And over the course of 80 years, we've basically seen that if you have 3 key ingredients in a very simple recipe, you can make magic happen. And it's 3 things. 1, just a safe start, right? And that requires a healthcare system. And by now, 1 in 4 children around this world is born in a UNICEF-supported health clinic. That's impact at scale. That's how we make it work, because we have the boots on the ground. The second one, safe drinking water and sanitation, because we know that that matters for early survival, it matters during childbirth, it matters for dignity of girls. 2 billion people have been granted access to safe drinking water and sanitation. And then, of course, vaccines. We know that that is at the heart of child survival. The fact that we were able, not just us as UNICEF, us as a global community, to reduce child mortality by over 50% in just 25 years was based on these 3 things. And supplies are an absolutely critical part of that equation. And it sounds like a technical element, and it is absolutely not. So access to supplies, to commoditive reproductive health commodities, vaccines, is at the heart of achieving the SDGs, is at the heart of getting it right for women and girls. And I have a lot of really good examples that I want to talk about later, but I first want to share the floor with all the wonderful panelists we have.
Thank you, Kitty. And you provided an excellent talk maybe for a question to Morena, who is a leader, I would say, in this space when it comes to vaccines. And Morena, when we talk, you said, look, it's critical to build equity, to have local manufacturing capacity outside of the high-income country. Can you say more about the efforts, for example, on the African continent, and how do you see the link between regional manufacturing and increased immunization of children and of women, and therefore better outcomes?
No, thank you very much for the invitation. And I think, Kitty just put a very fertile foundation, on which one can piggyback. So again, everybody will be reminded about COVID and what happened in COVID, and that many regions such as ours in Africa, were the last to get vaccines. And so there's a lot of momentum now about putting manufacturing in Africa, which sometimes people just think it's about bricks and mortar and putting up this factory, and that's fine, get on with it. But in actual fact, it's much broader than that, because firstly, it's the immediate access of vaccines, which is important. But I think it's important, particularly for us to remember that Africa in particular is having and will have the largest young population by 2050. And that's important just economically for us to dial that in terms of how, what about meaningful employment that we need to create. I think that's number one, that item, and I'll come back to it. The second item that I think we need to think about in healthcare in general, and I think it's not only particular to my country in South Africa, but I think also elsewhere, is that when you look at life sciences and education, it's essentially, I think hovers around 60% of graduates or people that are enrolled in healthcare and life sciences being women. Which means that as much as we're looking at the likes of factories, but the employment that is going to be created is really going to be run by women from an industrial perspective going forward. And so from an employment perspective, it's important. Ultimately, which is essentially what Kitty was talking about, is that the vaccines, in my area in vaccines, the ultimate recipients being the babies that will get there if you look at pediatric vaccines, or even the women when you look at HPV vaccines, and also the healthcare givers that are also going to be there are largely female. So I think, I always say at work that we are extinct species, because even at us at BioVac, we're 55% female in terms of the cohort. So when you look at all the levers, and it's a topic that we can't run away from, and we need to foster in companies internally and be able to recognize the engine, particularly in terms of just the gender equity, where our products are go to, and ultimately it being a real economic engine. So I always say that, and I'm passionate about what we do. I said it's a lovely business because on one hand, it's industrialization. it's sophistication, and it's healthcare, and ultimately you get to serve the population. So really on that end-to-end spectrum, I think this is certainly a topic that is very close to the industrialization of Africa, because those meaningful employment, and when you look at the cohort that needs to be working and doing that and the recipients, it's much more in line with this topic, and we need to make sure that Africa is also not left behind, and we need to look after our girls, and we need to look after our women, and not only as just recipients, as I say, but as part of the center of decision-making and of industrialization.
Thank you. So if I hear you, you're saying, look, there is an element of health, but with health come also wealth and the opportunity to thrive even more. Let me go to Aparajita. Aparajita, you have lived many lives at the Gates Foundation, but you have found your latest passion, I would say, in family planning, right? You lead this group. And you were telling me earlier about the clear economic case, right, around family planning. Can you speak a little bit about that, but also still, what are the innovations that we need to bring to market, right, to facilitate that, and also how Gates, what is the role that the foundation is having in incentivizing it?
Thanks. And again, a big thanks to the EIB group for having me here. I've been a long-standing partner with many of you in the room probably at various points. And I just think the value proposition of such an intensely committed organization, but also one with just a variety of instruments, which I think makes it a very, very unique player in the system. And I'll come back to that later. But again, a big thanks to you for the partnership and for all of the engagement with the Gates Foundation over the past many, many years. I think if you think of it from a product and an R&D perspective and women's health, decades of progress have created the illusion that we have a complete toolkit for women's health. And that's simply not the case. So if you take away one message from today, it is that the toolkit is incomplete and our work, therefore, is incomplete. I think if you think about women who want to avoid pregnancy, there are over 250 million women on Earth today who want to avoid it but do not have access to the products and services that can enable that. The challenge isn't just access, and it is in many ways a supply and an access issue. It's also the fact that the toolkit itself, the product offering, is incomplete. Here's a quiz, because that could be fun. What % of healthcare, research and innovation is invested in female specific conditions beyond oncology? Take oncology out. What percentage of healthcare spending on R&D do you think is invested in this space? Christian. No, I'm just kidding. I know some of you, so I'll just start calling you by name. But no, guess. Anyone have a guess? Not enough. Correct. Sorry? 14%, not enough. Anyone else? 5%. Anyone else? Well, that's always a good answer. Anyone else? Huh? Well, it was a McKinsey-led study, so I think you're cheating. But yeah, the answer is 1%. Now, anyone rational would say, half the population, and 1% of the research and innovation is going into this space. And women spend a good 25% more than men of a portion of their lives in bad health. So there is a need. I think we probably can agree with some common ground that there is a need. And yet the investments haven't been in that direction. And it's one of the reasons we as the Gates Foundation have announced that we are investing $2.5 billion in women's health R&D. It is the largest commitment of this kind, but we can't do it alone. I think that's the kind of partnership all of the people at this table, but all of you as well, can think of creative ways that we can co-finance things, and we are there. In terms of what the products themselves, I want to kind of perhaps just emphasize, they aren't just about the products, it's about also what kind of products women prefer. And I think preference, given contraceptives in particular, are very related to preference. There's discontinuation if a person doesn't feel like she can be on a method that actually suits her. And so this kind of more targeted, user-centric concept of a method development is very important. And think about, and contraception offers a thing that is very important to, I can say at least every woman in this room, is autonomy. And this is just undersold as a value, but it is one of the most important things. But family planning has a value well beyond that in terms of socioeconomic returns, and I'll come back to this at the end. But just let's talk about some of the methods that are in the next generation. We have a once-a-month oral pill, which will be using the same hormones as the daily pills, but you have to take them once a month. A microarray patch, which is like a Band-Aid, and that releases hormones over several months. A 6-month injectable that you can actually use, and this can actually be administered, hopefully, by women themselves. So these are just some of the next-gen products. There are a whole bunch of other things, non-hormonal contraceptives, technologies. We're working very closely with our colleagues here at Bayer on that, as well as many other European companies that are investing in this. On-demand contraception that can be used at the time of intercourse. Customized service delivery systems that actually help you adjust the dosage and the method. User-friendly fertility apps, which can be very helpful, and also technologies that reduce the discomfort of insertion of some of the products like implants or IUDs, which again, comfort matters a lot when you're dealing with methods of contraception. So this is about more and better variety, let's say, and I think something that R&D can actually help really advance. Finally, I'll just close by saying that the investments in this space of research and development, they pay for themselves. I mean, $1 invested in contraceptives or family planning can get up to $26 in socioeconomic returns. It's because you start so far upstream, preventing something that the family perhaps is not able to sustain, the woman does not intend, and then the effects downstream on maternal mortality, 30% reduction. Neonatal mortality, 50% reduction. It's just, and then on labor force participation, 20% bump. So there's just so many reasons why it matters and is yet highly underinvested in. So, I think the agenda is vast and we have a lot to do.
Thank you, Parajita. And you trigger another thought when you mentioned the women's health gap, as we call it. So women live longer, but they live 25% more of their lives in poorer health compared to men. And this gap is everywhere, in every country. We have the data. And from this discussion, you might have thought it's just a problem in low-middle-income countries, but it's actually everywhere. So I would turn now to the minister, to Alexandru, and ask, look, you've taken this problem quite at heart and are launching a few initiatives to say, look, what are the policies that enable prevention, early detection, right, and treatment? And do you want to say more about what Romania, for example, is doing to close the gap?
Yes, thank you. First of all, thank you for the invitation. And because I'm from the government, I feel thanks to the AIB for our partnership and for your implication in healthcare systems around Europe and also in Romania, because together we change a lot of things, not just about infrastructure, but also reforms and rethinking of healthcare services, and I think this partnership is very important for everybody. Yes, in Romania, last year we approved the national strategy for the cardiovascular and cerebrovascular diseases, a strong national strategy focused more on the prevention and screening. For sure, the public policies are adapted now to convince people, let's say, to use the screening and prevention, and I think it's an important message, this one, to convince people why it's important to have prevention, why it's important to have early detection, and how to put in place these messages in this context, because I want to discuss also about the medical fake news and medical disinformation, and if we discuss about the immunization and about the vaccine, I don't know how it's in other countries, but I know in Romania we have a very strong anti-vax community. They are very present in the online and on the social media, so the trust in immunization, the trust in modern medicine, it's really affected in many places because of this fake news and because of this disinformation. So we try to put in place the public policies for that. We try to communicate more, to convince more the people, and somehow to increase the trust in what we are doing. And if we discuss about the vaccinations, I think also for the governments, it's important to learn from failure. Because few years ago, when we introduced the HPV vaccine in Romania, we have a bad communication, let's say, and we had a lot of protests. Nobody wanted to have the vaccine, so it was a failure. After many years, last year, we introduced again another mechanism of communication. We create some legislative changes in terms of, we increase the reimbursement, so we have free HPV vaccine until 26 years, also for girls and boys. And what do you think? We double the rate of vaccination in HPV in Romania in just 6 months after this new approach, let's say. Public policies are very important. Infrastructure for sure is very important, but in my opinion, the most important thing is the communication and how we convince people to use the modern medicine and the medical services. Thank you.
Thank you, very true. And maybe turning to Kira today, you are here with 2 hats, if I can say so, right? You are the director of the foundation at Bayer, but of course you also represent Bayer more broadly. And in that, Bayer, of course, has been a champion, right, when it comes to, let's say, conditions unique to women, especially contraception. You're now also menopause. Can you say more about how Bayer finds the balance, right, or merges the objectives from a commercial perspective versus equity perspective, right, and the work you do with the foundation to close the gap?
Yeah, happy to. So at Bayer AG, we are actually a leader in women's health contraceptives. Many of those things that are in the current toolbox that you mentioned, that's actually also things that Bayer AG has invented. So it's a decade-long heritage there, and we've never continued to also invest in innovation. So the footprint is there, it's a sales contributor, and at the same time, and I think that makes also Bayer AG unique to a large extent, is that the sustainability agenda of the company is supporting access. So it's not only the product creation for the rich world, it's also the access for low and middle income countries. So those of you who are a bit familiar with us would say, maybe you have heard about a challenge to reach 100 million women by 2030 in low and middle income countries with modern family planning. That's a huge challenge that we are having, and not only a challenge, it's something that we're actively pursuing. We're already halfway there, and I think most importantly, the target is anchored into management incentivation. That means it's not just a morally right thing to do, to go into low and middle income countries and provide women access to something that they truly deserve. It's also paying off for the people in the company. So this is something good. So that actually goes along with also other investments, for example, for not only innovation, where we're now kind of in these non-hormonal contraceptives, but also it comes into local production. Already facilities in Egypt, for example, for production there. Further ones being under discussion in sub-Saharan Africa to localize production, create local jobs, create the knowledge, do the technology transfer, and also then, of course, provide products to the women in need. On the foundation end, to also complement that, we support actually that agenda, that sustainability agenda a lot, with creating capabilities to capacity building, targeted capacity building in low middle income countries. So how does that look like? It's specifically community health workers that are being trained, where products are also being made available. And it's also any medical societies that we're working in terms of spread the word, both on the health side, but also we span the bridge also to the agricultural side. Bayer has a large heritage, for those of you who may know, to also say it's very often it's female smallholders who not only have an interest in farming, but also it's women, it's mothers, right? So we are addressing them there also with products, for example, also in collaboration with the Gates Foundation. So it's an entire plethora of tools, instruments, and partnerships, I would say, we're taking from both the commercial side to the philanthropic side of what we do.
Thank you, Kira. And I think what you're saying, what we heard today is there is a case to be made. It's not just about equity, but there is a macroeconomic opportunity, the 1 trillion opportunity in GDP, but there is a business opportunity, right? So
correct.
Investing in women is just a very smart thing to do, let me say.
Can I maybe chime into that one? Because we do see the business opportunity, but also I would lie if I would say it's easy. Because it's not easy at all if you talk specifically contraceptives, because for years, for decades, it had been subsidized, it had been for free, it had been a subject of international aid. So I would say the market is, I'm an economist by education, the market is not really there in many, many different cases. So right now the challenge is there is a great need, as we have heard, the benefit is there, but the market needs to be created, and we need to be super creative with partnerships, with teaming up with the private sector, with the public sector, with philanthropists in order to create something that's actually viable in the absence of international aid.
Yeah, thank you. Let me pick up on what you said, because when I talk about the women's health gap and the root causes, for me there is science, because we don't know enough. There is data, we don't measure enough. There is healthcare delivery, because it's all tailored to a certain standard that is not based on women, but more on men. And there is little investment, the famous 1%. But in general, there is little investment. Now, for all of you, I will ask different maybe nuance, but what's the, how can I say, how partnerships and different funding mechanisms maybe, right, can help unlock? You spoke a little bit about how you change your approach in Romania. So I would love to hear your thoughts on this. How do we partner, and what type of institutions need to come together to close the gap? Alexandra, I see you're ready to pounce. Go.
Yes, because it's about money, so I need to manage some budgets. I think, in my opinion and our approach, it's to have some, or to increase the private-public partnerships. I think the state budget is not enough to increase the access, to reduce the gaps between regions, between people, and to increase the access to medicine and to prevention. So for that, in our country, we have public system and private system. And now we try to put it together to create a hybrid one named public-private healthcare system. I think when the private system, not just the hospital, the private hospital, but also the private insurance house. I mean, we need to put all together the public, the private, the insurance houses, the NGOs, the industry. It's very important to be near us because we can develop together. I'm looking in the room and I saw WHO. They are our partners and we work together a lot in our reforms, in our public policies. I think this could be the secret to put together all the system, the public one, the private one, the NGOs, and together to develop and to reduce and to increase the access and to reduce the gaps. Because in many countries, it's not just in Romania, this one, we have differences between urban area and rural area. Mm-hmm. We have differences between different regions. Mm-hmm. And for sure, we have a lot of differences in terms of access between member states in Europe. So I think our new vision needs to be to reduce these gaps and to increase the access. But when you increase the access to prevention and to screening, we face the next step. The next step, you discover more. When you discover more, you need to treat more.
Yep.
So for that, you need to have infrastructure ready to treat more, because if you discover more, let's say, oncology pathologies, and you don't have the infrastructure ready to treat them, you will increase the waiting list. So I think we need to face all the issues and to put it together. We are lucky because of AIB, so together we'll build another few hospitals in Romania to be able to treat more, but it's not enough to discuss just about screening or just about prevention or just about one component. It's important to have the whole picture because it's to be fluid, let's say, for the patient.
Thank you. So it's a full system approach and it needs multiple partners to come together. Kitty, can I turn to you and say, what have you seen as partnerships that are effective, in particular in your area, when it comes to children, adolescents, and women?
Look, I think if I'm really honest, and I'm Dutch, so I'm allowed to be honest to the point of being rude, I think we need everybody in the room, whether it's CSOs, it's foundations, it is high net worth individuals, it is corporate partners, but to get to scale, to sustainable results, no matter what we do, we are going to have to work through domestic systems. Domestic budgets, domestic healthcare systems. We can have supplies for all you want. If there are no community health workers that are capacitated, it will not work. So for me, working through domestic systems where sort of the domestic workers are able to co-design, co-create, co-implement whatever solution we have is essential. It is not going to be enough, right? So we do this, for example, I know we talk a lot about medical supplies here, but with nutrition supplies, right? With the Child Nutrition Fund that we have set up with multiple partners here also in the room, we're trying to treat undernutrition in pregnant women and children. And the way we do that is matching domestic funding. Because you want to have that sovereign decision that they put their money where their mouth is and invest that in children and pregnant women. And by matching funds, you can actually unlock and leverage that domestic funding. Still will not be enough. So we're also trying very new ways of funding. For example, with the Gates Foundation on the MNCH accelerator, where we have identified, really with a dedicated look, which are the supplies, reproductive health commodities, vaccines, other medical supplies, that are most critical for maternal and child mortality and morbidity. And let's make sure that we have accelerated supply at an assured quality, delivered in an agile way through our systems and boots on the ground. We have developed something that is called VII, because even if you have products and even if you have a capacitated community health worker system, what is very often a huge problem is interrupted financial supply, budget shortfalls. And so we've developed, again, together with partners, the Vaccine Independence Initiative, started during the COVID years, as particularly African countries were really, really struggling to get access. And if there are temporary financial barriers, the Vaccine Independence Initiative comes in with what we call bridge funding. And in the past years, we have supplied $1.7 billion worth of temporary finance. So we avoid stockouts, which actually cost women and children's lives in more than 100 countries. So I think we also have to start thinking of new, innovative ways to actually get supplies and services and domestic institutions in a state where they can deliver for women and girls in a much more equitable way than we've seen in the past years. It is doable. And I did want to really give a shout out, and I can't remember, I think, was it Aparacha who mentioned the community health workers? So for me, I really want to also highlight that if you have great policies and you have great supplies and you have great finance, but you don't have the local supply, not in the capital, but in the capillaries of society, far out where there's no one to be seen, but where women and children are, if they are not capacitated to deal with these products and tools, we still can't work through it. And I think these are things that we very often tend to forget. They are often women. It is their job. but we don't invest enough in training. And if I give you one very simple example, what we know from research in climate change, for example, is the impact of heat waves on pregnant women, right? So we know that when temperature goes up by 1 degree, the level of stillbirth goes up by 5%, and preterm labor goes up by even more. So children are born at a disadvantaged level. How do we ensure that community health workers, because women themselves don't understand it, community health workers won't necessarily understand what's happening in that pregnant woman's body. They need to be capacitated to detect, diagnose, and treat it. And that is where we all still need to invest a whole lot more to make sure that there is really equity beyond supplies. But supplies are going to be a key part, as is domestic finance and community health workers. Thanks.
Thank you, Kitty. And Kira, if I turn to you, listening to Kitty, right, that you have had many partnerships, public-private partnerships, or with different stakeholders. What do you think are the traits of successful partnerships?
I think it's what we've also heard earlier in the other panel and also others, is to be super aligned on the outcome. And also be very clear what each partner is up for. So kind of what are their drivers, what is the success to them, and then get the right partners together that are a match. So we have seen actually really great outcome-based collaboration on the Bayer side, for example, also with the Johns Hopkins University, also induced by the Gates Foundation. On family planning, it's called the Challenge Initiative. That's an initiative we're in for years already, reaching tens of millions of people, of women with respective contraceptive solutions. That's one thing. The other thing, and I'm talking here rather the philanthropic side as well, is to not shy away to create the impact, as you, Kitty, mentioned, for the community health worker parts, to also get philanthropists into the boat. There's many actors in the system, they all can contribute. You need to get the right ones that have the respective also feet on the ground, that have the financial power, the knowledge, and also what I've been perceiving as a plus. The moment you go local, you need to have local government on board, ideally. Yeah. It's not always possible in the first instance, but the moment local government has skin in the game, that's where it's typically the magic happens, because they again have the system, they can design it accordingly, they have the incentives, they can actually make the magic happen. So you guys play a major role.
Kitty, you want
Could I add something? Because I think where it happens and how you bring different partners together, and of course I forgot one major partnership with many of you here in the room, which is what we've done with the European Investment Bank on polio eradication, which is a huge program, 500 million with WHO. I'm sure you're in the room, but it's very dark when I see you. So together with the Gates Foundation and the European Union, to make sure that across WHO and UNICEF in the field where wild polio is still prevalent, we're able to detect and treat immediately and vaccinate. And that has been one of the most successful programs because it is deployed at scale with partners that trust us. We have the boots on the ground, but we could not do it without the innovative financing scheme that we have developed, because quite frankly, we're the UN, we can't take loans. We can't put our assets at risk. We're a different beast. And so we had to come up, and it took us very long to get there. But when we did it, we were able to deliver like in the most agile way we've ever had before. So I just also wanted to give EIB and Gates and WHO, European Commission, a shout out and thank you, because this is what matters. This is what equity looks like in Pakistan, in Afghanistan, in places where wild polio is still propping up its ugly head. So couldn't resist saying that.
Thank you, Kitty.
I do have another point to add that sometimes is forgotten, and that's innovation in terms of business models. Very often, we've seen that in several cases, it's the social entrepreneurs, very often women entrepreneurs, that have great solutions for their respective environments and countries, that have the potential to create impact at scale. We have seen great examples in the insurance space, both in the terms of health insurance, also in terms of climate insurance for smallholders. that's the kind of an innovation that I find really most interesting. So not forgetting that, driving it, including it into a continuous system that's further evolving with a huge impact objective, that's, I think, also a great factor.
Yeah, thank you, Kira. And maybe on the same lines, Morena, when we think about vaccines, to your earlier point, it's not about putting a plant somewhere and things magically will happen. It's quite a complex, system. What are the partnerships and the policies that you've seen successful to scale?
Well, let me start firstly with a problem that I'm not sure if other middle-income countries are probably facing, particularly in the women's health space, but certainly in children and coverage, this is gaining to be much more of an issue. And people that are in the immunization world will understand what I mean, but maybe let me simplify it. So there's a concept called zero-dose children, which essentially means that children, there's an increasing number globally of children not even getting a single vaccine. Now, sometimes you talk, okay, maybe the child didn't get all the immunization, but then there are many zero-dose children, and that percentage is increasing, and the immunization in the world is worried about that. But what we are finding is that because the low-income countries, which are supported by donors and sort of all of these other mechanisms, are better equipped, to reach through community healthcare workers, through the programs that are running in the communities, because they are supported, are actually even better than middle-income countries. So if I can make South Africa as an example, South Africa is facing a bit of a problem that I think is going to turn out into some probably outbreaks at some point, because the zero-dose children are increasing. We're not eligible because we're a middle-income country, so the country must sort itself out. But I don't see, what a country like ourselves, in terms of when I look at the neighboring countries, when I look at the support that they're having, in terms of going to communities, having this coordinated approach. I'm not seeing that in my country, and I think other middle-income countries are probably facing the same. So you'll find that maybe some of the things that pertain to access of, so this is not about a lack of money now, because we always complain about money, but there's some things that money can't solve. And it's really about this coordination where you find that middle-income countries in some areas may lag behind low-income countries, because firstly, they have to sort it out themselves, but they don't necessarily appreciate or don't have, or whatever they're deploying onto their budgets, on the hard stuff. Okay, we're buying vaccines, we're buying pharmaceuticals, we're buying contraceptives. But not enough resources are put about how are we actually going to make those accessible in this changing environment. As you said about social media and anti-vaccine campaigns, are we adapting, to make sure that products that we have are actually reaching this new generation that looks at life differently, is accessing differently. So I don't have an answer, but I'm just saying I think there's a ticking time bomb that's coming, that as much as normally we look at low-income countries and say, okay, that's the problem, that's what we need. But middle-income countries are facing a bit of a challenge, and I can only assume maybe in women's health that it's probably similar. Because if it's like that in vaccines and you get zero-dose children, then these children are not getting to the clinics that they're not supposed to. So the people that are supposed to be getting them, where are they? And we know that a large part of those, are female in nature. So there's something in the system that I think we need to look out for. And it, not only in terms of outbreaks, but it ultimately impacts the economy, because governments will always be responding to outbreaks. We as manufacturers want a sustainable visibility in terms of volumes. So I think it's something that around coordination that I think middle-income countries sometimes are sitting in silos, and I think it's an area that needs to be addressed.
Thank you. And maybe Aparajita, one reflection, because we were saying the world has changed so much in the last 6 years. There have been continuous crises, right? More global, I would call them, because crises are everywhere, as also Kitty was saying. But there is also tightened financing. Of course, Gates is an exception with the 2.5 billion devoted to women's health. But if you reflect on the lack of funding and also the lack of understanding maybe of conditions, what do you think an institution like EIB or other financial institutions could do, right, to spearhead innovation or enable that?
So in one word, I would say alchemy, which is, I think what's very valuable in the space of development is grant money. everyone wants the money that's the highest risk, risk capital that can offset the most, the first loss position in the case of many stacks that the EIB does. And that money, the pressures on grant financing are just tremendous right now. And that means that world of aid as we know it, it's unrecognizably it's not going to be the same when we go forward. So how do you alchemize, if you will, that grant money into non-grant deployment? And this is something I say because we've actually worked on something like this with the EIB. Many partners in the room involved, but the idea of a human development accelerator, which Nicola also mentioned, this accelerator is essentially a combination. You can call it blended finance, but it's a bit more than that, in that you can take the combination of risk capital in the form of grants and subsidy in the form of engagement with the European Union, the European Commission's own support of the EIB, and then the EIB's just giant balance sheet and set of instruments, and be able to try and create products, financial products, that meet the needs of not just countries, but entities that need the support. Kitty, you mentioned the polio transaction that was linked to this Human Development Accelerator, and the idea was you were able to take grant money and make it something that looked, non-grantish enough that it fit an instrument that could be jointly done with the EIB. This kind of combination of instruments is extremely important as we go forward, because we're running out of grant money globally. And so how do we take philanthropic capital, domestic budgets in countries, but also the kinds of balance sheets and the instrumentation that the EIB offers. It was a $1 billion facility, and we're really pleased that even we're working with the likes of Morena here and BioVac supporting vaccine manufacturing, but there are many other applications of this facility, and we're very, very pleased with that kind of deployment. We think there needs to be much more of that. That's one. I think the other is we're proposing, and with the EIB again, working with UNFPA Supplies, which is the big procurer of contraceptive commodities globally, and trying to basically de-risk what are donor contributions to that entity, and try to basically front-load financing so that you can create predictable orders from a big procurement agent to companies, and you get lower prices. You get lower prices, you get more steady supply, you get through some of these bridge requirements that I think Kitty also mentioned. You need a steady supply of product, and you ideally need to place multi-year orders with companies to get good prices. If you just keep ordering every 6 months, you just won't get the same price. So there are market-shaping mechanisms that we're actually also engaging now with the EIB on. We're very excited about this engagement and hope it will come down soon to a conclusion. And I think in general, I would just say we just commend the partnership that we have. The EIB has been able to really step up in this space, along with the European Commission, of course. But I think that this kind of joint partnership, which enables, bringing the best of each player's resources and making the most out of it. And I mean by that, literally every last drop you can get a value from that $1 that is in the system, or €1. And I think this idea of doubling down on finding these innovative solutions, and just even if it takes a long time, I know these transaction costs can scare everyone, us sometimes, the risk department sometimes, various players, but it is worth the effort, I guess I would say, because at this point, we don't have a choice as a development community, at least, and we have to, kind of squeeze every last penny of value out of whatever is out there in the system. And we are very excited to partner with several of the players here in the room, but also think that there's room for much, much, much more. So look forward to that.
Thank you. Any questions from the audience?
Hi, I'm Silvia Rovere. I'm the chairman at Poste Italiane. Talking about health equity, I'm a little bit surprised that nobody mentioned one of the major issues that affecting, according to UN, more than 230 million of women and girls in the world. I'm referring to genital mutilation. Here is not necessarily investing in producing vaccine or distribution. It's just a question of how to stop this horrible practice that affect the physical and psychological health of many girls and women. Unfortunately, this figure I mentioned is increasing because the states where this practice applies have an increase in demography. So I had to excuse that I had to go because I have to catch a flight, but I think this is a topic very important. Thank you.
Thank you. I don't know if anybody can respond to this, of course. Fully agree with the comment. Kitty?
Look, if this would be easy, we would have done it, eradicated it. I mean, this is one of the most horrific mutilations that you can do to a woman and a girl. And that it's absolutely a stain on our collective humanity, as far as I'm concerned, that we're still allowing this to happen. Obviously, UNFPA, UN Women, ourselves as UNICEF, we're very actively involved in trying to combat that. We do that by trying to change cultural norms and embedding that in legislation, because that's the only way that you can effectively do that. It requires long, hard slog, patience and perseverance. It's not going to happen tomorrow. It requires sitting with the mullahs and talking what other ways of transition you can think of when a girl becomes a young adolescent. There are so many ways in which you have to work with and through the local culture. And I do agree, I am afraid we're going the wrong direction as a world community. We actually now see in certain countries that it is going up. And interestingly, I mean, I have to say this because we just produced a report on it, there are very strange ways in which the increase of FGM, but also girl marriage, is actually linked to climate change. Because what you see is that the economic knock-on effects of climate change, be it flooding and therefore not being able to get to your market, be it droughts and your crops withering on the field if you're a subsistence farmer, the economic knock-on effects in certain regions compels poor parents as a terrible coping mechanism, but the only one they have, to sell off their girls, right? And we have the facts from Bangladesh. It's pretty devastating. If a heat wave lasts longer than 30 days, girl marriage, age bracket 11 to 14 year, goes up by 60%. We've seen this in West Africa as well, including rising rates of FGM. So this is something where A, we have to be very alert, B, we still have to build a lot of awareness, and C, we have to come together really to combat this, but it has to be in a respectful way. We can condemn it because we feel it is a violation of a girl's rights, but unless we get the local authorities, including religious authority, to think that way as well, that's where we have to invest our human capital, if you will. It's not going to change. So, but I completely agree, it is a terrifying practice.
Thank you.
Good afternoon. Khalil Radigi from the One Campaign. I have a question on, this debate about structural interventions, transformative gains versus more incremental gains. And we often hear, at the One Campaign, we work on Africa and economic development in Africa. We often hear economists tell us that we need transformative advances to see transformative progress in Africa. For example, much deeper economic integration across the continent to reap economies of scale, those types of benefits. So my question for you on the panel, specifically on reproductive health products, do you see that as a meaningful, agenda of economic integration? Is this the kind of thing that will deliver the kind of change and the change of scale for both the R&D side or the distribution side for reproductive health products, or is it not, in this case, it's not really where transformative benefits are expected to come from? And I'm interested from the point of view of companies, BioVac, and also the foundation or UNICEF.
I saw Parajita wanted to comment.
I can maybe just kick us off here. It's a very expansive question. I think the short answer would be there are many countries in Africa in particular that are very energized about reproductive health because they do see these benefits. And I think they see them in terms of, as I mentioned, the downstream benefits of intervening early on an unintended or unwanted pregnancy on just at the communities, the society at large, the entire national productivity and economy. So I think that there is an increasing even demand, I would say, for this. And yet there are also many headwinds, political and otherwise, that the sort of reproductive health community is facing at large. But I would say leaning into where the door is open, I think we should not be at a place where we are not all collectively making the most of that, where you have a willing health minister or a willing finance minister or a head of state or even a state level or in a federal system, a state level champion. I think finding there is that sort of, I would say, momentum. And I think it's up to us to make sure that we make the most of it as a development community when that opportunity exists. But I do see them making that connection between commodity financing and ensuring supplies are where they need to be at the last mile, and the actual economic and social and just general well-being benefits that reproductive health offers.
Thank you.
I would build on that and say it's all about the market creation also that we said earlier. Again, before a lot of donor dependency, you need to really create local markets, whether you need to be super strong integrated in terms of, like with Europe and Africa, that's, I think, a different story. But I think the first step is that you are unleashing the power of women for themselves, for societies, and for the workforce. And then actually, those women are then, give them education on top, for example. You are releasing an entire workforce that can be either on the smallholder fields, they can be very productive, they can go even into universities, they can become community health workers, but it's all about those starting chances. And again, it's building the markets for those starting chances.
Thank you. I'm told we need to close, unfortunately, but let me thank all the panelists, but also summarize quickly. There is a women's health gap, and the gap is in every country, and it shows in different forms. It might be access to the right treatment, but very often is access to care. Healthy women can be empowered economically. They create stronger economies, and actually they also drive health of children, by the way. And so there is a catalytic effect on investing in women's health. To close this gap, as you heard the panelists, is not one single actor that can do that. We need a concerted effort that goes across the philanthropies, financial institutions, innovators, of course the countries themselves, and all need to come together, right, to close this gap. Let me finish by saying, look, investing in women, as I was saying earlier, is not just the right thing to do because we want to be good. It's just a smart thing to do. We show the business case from an economic perspective, from a business perspective. And by the way, health decisions in the household are driven by women. And for each woman you reach, there are 2.5 more, right, that you can get to because they influence the decision for the children, for the elderly, for the spouse, and they talk to friends. So I hope you will take home this message, right? And remember, you were all born from a woman, so very important to take care of them. Thank you.
Thank you so much for that wonderful panel. We're moving now on to the final panel.